like to thank everybody very much for turning up, especially on an evening. We're going to be talking today about one of the most exciting new things in venous surgery. There hasn't been much of huge excitement probably since the advent of the endovenous techniques. There's been lots of little improvements and lots of things going on, but the last major revolution in venous surgery was probably endovenous surgery, and the big revolution before that, of course, was the venous duplex ultrasound. And these were massive changes. The venous duplex ultrasound in the sort of 1980s, 1990s suddenly let us understand veins for the very first time, and we suddenly realized that all of our previous thoughts had been wrong about them, descending reflux, etc., all based on anatomy and venography. Venous duplex made a massive revolution, and after that the endovenous thermal ablation and endovenous sclerotherapy under duplex control has had a huge change, as we all know. And now looking at pelvic congestion, looking at perforators, but all of these are just modifications of what we know. The next biggest change really has been this completely non-invasive way of doing surgery of varicose veins and venous surgery with the high intensity focused ultrasound. Tonight I'm absolutely delighted to be joined by three absolute experts in this area, people who have experience, who have not only used the machine but have actually put their minds to how to use it, and have got experience on patients. Like all of us, made some mistakes, I'm sure, which we'll probably share in the question and answers, but also finding the way forward. And I think this is already a technique that is useful, but I think it's just going to keep on getting better and better as we use it and find out more about it. And we'll go on to Teresa, and Teresa is going to talk to us about why SONOVEIN is becoming revolutionary in treating varicose veins. Thank you.
Okay, thank you. Okay. So can you all see my presentation? Yes.
Yes.
On the screen, yeah. Okay, so why SONOVEIN is becoming revolutionary in treating varicose veins? That's a very good question, and I will do my best to answer it today. So these are the topics I will discuss in this talk. So at first we will have a brief introduction talking about us and what we do. Then we will move to all the techniques and what the current guidelines say about them. And then I will focus more on SONOVEIN, so its effectiveness and safety mainly. And then I will talk about what it means for the patient and the practitioner, and finally our conclusions. Let's see if I could answer the questions. So about us, the partnering between Teracleon and Instituto Vascular Internacional started in December 2019. So we did our first cases in March 12, 2020, so just before lockdown, and we had a learning curve of 15 patients. And about me, as you say, I'm Teresa Reyes. I'm a vascular surgeon. I work in Instituto Vascular Internacional and at HM Hospitales. And in June, I became the first woman in the world trained to treat with focused ultrasound through SONOVEIN. The first of many, I hope. I wanted to talk a tiny bit about CHIVA, because basically it's the method we use. So, as you know, it stands for the Ambulatory Conservative Hemodynamic Correction of Venous Insufficiency. It is minimally invasive, and its aim is to eliminate venous shunts by disconnecting the escape points. You do not need to do only CHIVA when you use SONOVEIN, but I wanted to talk about it just a tiny bit. So when I talk about our results later on, you know what I'm talking about. There are so many different techniques you can use to treat your varicose veins. So up to 2000, you will have the stripping of saphenous vein. In 2013, there was this big revolution with the appear of endovenous thermal ablation. To that, we had new techniques like foam or Clarivein. And in 2019, SONOVEIN was born. Let's see what the guidelines say about it. So the NICE guidelines from 2013 say that for people with confirmed varicose veins and truncal reflux, you should offer them endothermal ablation first. If that is not possible, then offer them ultrasound-guided foam sclerotherapy, and then surgery should be your last option. And the European guidelines follow that. So for non-complicated varicose veins, surgical treatment is recommended instead of conservative management. For the treatment of raised saphenous vein reflux, endovenous thermal ablation techniques are recommended in preference to surgery and to foam sclerotherapy. For the treatment of a small saphenous vein reflux, endovenous thermal ablation technique should be considered as well. But the access to the small saphenous vein should be gained no lower than mid-calf. As I said, SONOVEIN is quite a new technique, so it started in 2019. It's only 3 years old. And when you have such a new technique, you really have to talk about its effectiveness and its safety. And that's what I'm going to do now. So for that, I'm going to talk about our results. We had a prospective study with patients treated from March 2020 to June 2022. The primary endpoint was to see its effectiveness in the leg point vessel closure. We treated 96 limbs in 90 patients. 61 were women, 29 men, 78 were primary treatments, and 18 were retreatments after other techniques. So what is the effectiveness of the other techniques available? Well, the occlusion rates of EVLA vary between 77 and 99 at 1 year. Compared with surgery, most studies report no significant difference in varicose veins recurrence, so clinical, or recurrent reflux, according to the ultrasound after treatment. Other studies report a high recurrence rate after surgery, so 20% versus 4 at 1 year, or after EVLA, 7.4% versus 0% at 2 years. And why is that? Well, this is an image by Mark Whiteley that I think just shows it perfectly. So the problem with endothermal ablation is that sometimes you might cause an intimal or a subtotal mural damage that would lead to intraluminal thrombosis, and then is when recanalization might happen. The good thing about HiFU is that with the SONOVEIN, you will cause transmural death that would lead to fibrosis and finally the involution of the vein. And these are our results with SONOVEIN. So the mean follow-up was 6.2 months. And we had a leg point closure primarily in 89 patients, so 92%. In 7 patients, we needed a second procedure. So 3 patients had to go for a new SONOVEIN after that, and 4 had to go for foam. But at the end of follow-up, the leg point was closed in all 4 patients. Now let's talk about safety and the complication. In our study, we had 6% of superficial vein thrombosis, which is quite similar of what you would find with EVTA. And we didn't have any case of this vein thrombosis and no cases of pulmonary embolism. And what you have to understand is that SONOVEIN is completely non-invasive. So you have no cuts, you have no wounds, you have no punctures. And that means that all the complications that might come from that just disappear. So you will not have any kind of thermal skin damage. You will have no bruising, no hyperpigmentation of the skin, no hematoma, and of course, no wound infection because you have no wound. But what does it mean for your patient? This technique can be done in an outpatient regime. They don't need any anesthesiologist consultation prior, and they don't need to stop anticoagulant medication. There is no age restriction, and they can go back to normal life immediately. And this case is a very good example. We had this young lady, she had the treatment on Thursday, and then 2 days later, she got married. So when we say that they go back to their normal life immediately, we really mean it. And for us as a practitioner, what does it make? Well, you do not need any sterilized environment, so no need for an operating room. It's quite fast, especially due to Chiba. The machine is very easy to use, and it can be applied to any type of varicose veins challenging to other techniques. As you can see, the screen will just take you step by step, and it's very easy to learn and to use. Now let's talk about cost. So is it cost effective? Well, we don't have any studies so far about it, but in my opinion, it's totally worth it because yes, you have to make your first investment, but after that, all you do is save money. You save money because there is no workload for the patient, because there are less complications, because you do not need an operating room and everything that comes with it, and because you will need less consultations. So let's go back to the question, why SONOVEIN is becoming revolutionary in treating varicose veins? Well, because it's the first and only totally non-invasive method for treatment of varicose veins. The closure rate seems to be at least as good as endovenous thermal ablation in the same follow-up period, and it has less complications because it's non-invasive. For the patient, you have no restrictions due to their medical history or the varicose veins, and they resume their normal daily activities immediately after. And for the practitioner, it's very easy to learn, it's very easy to use, it's quite a fast technique when you learn about it, and you do not need an operating room. So we might say that as a totally non-invasive treatment option for varicose veins, HiFU is the next potential disruptive technology in this field. I wanted to give a special thanks to Professor Izquierdo. He let me borrow many of the photos and the slides for this presentation. And of course, thank you all for being here today. I thank to the College of Phlebology for having me here.
Thank you very much for an excellent and very, very clear presentation. What we will do is we'll have questions at the end. So for the people who are attending, on the top bar of Teams, there's a Q&A. So if you click on that and ask any questions in that bar, then we will get it round to the most appropriate person afterwards to answer, or for the panel. Okay, now I hope that we've got over our things. We're going to now ask Paolo to present his presentation.
Confusion.
Thank you, Paolo.
Do you listen to me now?
Yes, we can hear you.
Okay. I think I have to talk with my phone, and I try to show my presentation. If you can see that. Do you see the presentation?
Yes, it's just come up.
You see the slides?
Yes, if you can just click on presentation view, F5, or on the little screen, because we can see the whole of PowerPoint at the moment.
So do you see that?
We can see it, yes.
Okay. So thank you to Teresa, and I agree completely with what she's saying. And the message I want to bring today is to say, starting from the point of view that the HiFU treatment is not very, very young. It's quite old, because to find a way to produce a focal heating in the center of paraffin blocks was discovered in 1949. Then in 1989, it was tried to treat also varicose veins in experimental dogs. So the concept is that we can use high intensity focused ultrasound to treat solid tissue and to have an apoptosis or a cellular necrosis. So in Italy, in Milan, is used to treat prostatic tumors, breast tumors, and thyroid tumors. Okay. They don't see the slide.
If you could just put it on as a presentation.
They say that don't see the presentation.
You could just put it on. Thank you.
Go back on Teams.
Yeah.
No.
Yes.
That's better. Yes, we're back to you now. We had lost you.
209. Now you lost me.
No, keep speaking now. We can hear you now.
I'm speaking now. Do you hear me?
Yes, we can hear you now.
Okay. You see 209 is, I was telling that ultrasound is used for cancer treatment. And in 2017, we can say that we can use for a wide range of application. The HiFU concept is that outside of the body, we can concentrate in a 2 or 3 millimeters target point the heat and to have a cellular damage. HiFU in phlebology was experimental in sheep models to treat varicose vein, to treat saphenous vein, and the histological findings were similar to the ones reported after radiofrequency or laser based. So we know, and you know, that Teresa told that the machine is completely in the office procedure, and the SONOVEIN can, using heating, bring in a place, specific place, you check with your ultrasound the heating. What I want to share with you today is what is the effect, what we do exactly with ultrasound in the vein. We can get a complete extravenous thermal ablation, like in late treatment of radiofrequency to perform hemodynamic phlebology, or we can also have a selective extravenous thermal shrinkage. But to know this, we have to show how happens during in histological samples. This is a slide I received by SONOVEIN with a sheep model. They had a complete occlusion, so we can get this. But we did a study. We did 120 cases in Italy, and we, in patients scheduled for surgery, we decided to treat before with SONOVEIN. And we removed 4 GSV segments treated with SONOVEINs after 24 hours, 7 days, 14 days, and 4 months. The aim of the study is to monitor the evolution of the thermal extravascular damage, because remember that the SONOVEIN is an extravascular, it's not endovascular. So the heat damage starts from adventitia, not from endothelium. This is very, very important. But follow me and let's to understand what's happened after 24 hours. After 24 hours, we can have, number one, a media and adventitia edema. We can start to say some with 100 hematocytosine. Number two, you see hemorrhagic infiltrate. The endothelium is normal. And number four, hyalin deposit starts, and there is a reaction of a myositis in the media. But we'll follow this. What happens is not the same patient, obviously. It's another patient over 7 days with 100 magnification. Hematocytosine, we see number one, the edema is still present. The hemorrhagic coagulative necrosis is larger, and the hyalinization and the progressive generation of the muscular layer, this is the step leading to fibrosis. And endothelium is still. And what happens after 14 days? The 14 days is the moment where the hemorrhagic solution, so the complete reabsorption. You see this, that the hyalin deposit is at 200 magnificence, and the step is leading to fibrosis. What happens after 4 months? After 4 months, we can see in this very large image that vein is this one inside. No, obviously, is completely closed at ultrasound image. The perivenous tissue is very interesting because we can get a fibrosis and to have like something that increase stiffness in our venous and perivenous tissue. And we can see this after 4 months. The vein structure is a complete wall and small, very small lumen, but without any possibility to have any flux inside because the vein is anatomically closed. The perivenous tissue, in the perivenous tissue, there is white cell, fibroblast, and lipid changes. This pattern will enhance vein stiffness. After 4 months, we see that the hyalinosis process of media and very, very hyperplasia of the intima. This changes is very interesting, as similar to the same that happens in the myocardial infarction. So there is a degeneration, there is the hyalinosis. What's hyalinosis? Hyalinosis is a tissue degeneration, chiefly of connective tissue or muscular, in which structural elements or affected cells are replaced by a translucent homogeneous material. And in the time, this can be replaced by fibrotic tissue in the time. Examples in human pathology: the myocardial infarction, renal and splenic artery in elderly, microarterial hyalinosis in kidney failure, hyalinosis in arterials in diabetic syndrome, or other rare syndrome. So we can say that the coagulative necrosis that starts after 24 hours and increase in 7 days, and then it will disappear after 14 days to gain hyalinosis and fibrosis, is exactly the similar we have in the myocardial wall after hemorrhagic infarction. Also, the histological pattern is quite similar of what we get in our vein wall. So the HiFU effects on vein wall is with a low energy protocol, because we use a low energy protocol to get the shrinkage more than closure, but we can get closure when we want to do that. Is a coagulative necrosis, then a hyalinosis, hyperplasia of tunica media with myocyte reaction, which will result in thickness and stiffness of the vein wall. There is a steatophagic reaction of the perivasion tissue, and that will increase also the thickness. The endothelium can remain also intact, but because it's different, the heat comes from the outside, not from the inside. So it's the last one to be treated. The histopathologic process starts immediately after the US attack and continue and remodels the vein wall up to 4-6 months. This is very important for the clinical outcome, because we have to inform the patient that when we treat GSV, or we get to close a collateral vein, the results can be get after 3-4 months. And it's otherwise possible to get, a complete obliteration of the vein wall, even if you can have endothelial cells, but we have only one samples intact. So, depending by the energy we deliver, it's very important, because we can decide what to do in our vein from the outside. We can deliver many spots, we can get a modulation of the HiFU effect on the vein wall, and decide before if to get a complete vein thermal occlusion, an obliteration of our vein, or if you want to have a strong vein shrinkage, I will show you now, or it's very new because it's a recent experience with a mild shrinkage, but use a very low energy product. And it's very effective in hemodynamic treatment. But we can also use SONOVEIN if we have a demolitive philosophy, if we want to remove a vein. In fact, research is now continuing to identify the ultrasound imaging counterpart to the histologic pattern. So, for instance, here we have a complete occlusion. This is the cusp. So the vein is not compressible, so it's closed. Why? The vein is the GSV and the collateral. We perform in this case an asphalt method. So we see the GSV patent and open, and the collateral completely closed. Or we can get like a half moon cockade WA. I will show you. This is the half moon effect. So the hyalinofibrosis sometimes don't get to the closure of the vein. So you have an effect in echography. In echography, you can get the wall is, in this case, not completely occlused. This is a half moon effect. So you can understand that the flow in this vein is very, very, very small. So we can say that clinically, the varicose vein will disappear or very reduce in volume, and the symptoms disappear. There's another effect This is a cockade effect. The cockade effect is when the energy delivered is distributed equally in the wall, and the total vein diameter of 6.2 millimeter was incompetent GSV remains with the 3.4 millimeter competent or incompetent, doesn't matter, but it's very, very small diameter, and we have a volumeless reflux. In the longitudinal pattern, this is called, we can call this a double railway with a thickening of the vein wall. This is a very low protocol energy. This is a patient we treated trying to have only to see what happens. And we can get also a wedding ring image. So the hyalinosis is not very, very strong. This is a 30 days after the treatment. And that we want to discover in the future. But the message is that HiFU exothermal robotic treatments is actually the only one that can offer you this different, totally non-invasive option. And these open a window on a complete different philosophy for the treatment of venous insufficiency. Thank you for the attention.
Thank you very much, Paolo. I hope most people were able to see your very, very interesting slides. I was able to see them on shared content. If there's any problems that anyone didn't see any of that, please come back later on and we will be posting this whole talk edited, so we'll be able to see those slides better along with Paolo's talk. I know that some people have been saying that there's been a difficulty in viewing them. Also, as we're going through, please remember, if you do have questions, click on the Q&A button at the top so that we can have the questions lined up for the speakers at the end of the presentation. If you could stop sharing now, thank you, Paolo.
Oh, how can I stop sharing?
Thank you very much. Now we're going to go to Guillaume, who's going to present to us a very interesting talk on which patients are best for the HiFU procedure. Patient selection is always one of the most important things for any new procedure. Thank you very much. Thank you very much.
Okay. So you can see the presentation.
Yes, we can.
Okay. Hello, everyone. Good evening. So first, I would like to thank everyone at Guillaume for providing us this device, and you, of course, Professor Mike Whiteley, for having me to this presentation, and our patients for their patience and their help to this venture that we started, that I personally started in 3 years ago. So who am I? I'm just a vascular French physician, and I've been dedicated to phlebology over the last 20 years. A few personal achievements that we don't really care about, and we run here in the north of France a venous center when we do around 2,000 surgeries a year, mostly laser and phlebectomies, and I've been working with SONOVEIN since March 20. That led me to treat about 150 veins since then, and I'm not a Shiva believer for the moment. I have to say, I like destruction, and I focused on great saphenous, short saphenous vein and perforators. So, which patients are best fit for HiFU procedure? You gave me here the kind of the hot potato question, you know, because I'm going to be the bad guy here, because I'm going to tell you that no, everything is not possible, or what is possible, or what is not. But as you can imagine, there are a lot of breakthroughs with this technology. So, in order to understand this presentation, to me, what does best fit mean? First, you have the technical requirement of the technology, about the vein, about HiFU and SONOVEIN. Then it's a thermic treatment, so you have to respect the rules. And of course, we have different expectations, as you could understand. Shiva as well, destruction, but we also live in different healthcare systems and different ecosystems. So, for instance, here in France, I'm not allowed to do any office surgery, so laser has to be done in an operating room. And of course, we have our patient expectations, no operating rooms, if possible, and sometimes a solution to a recurrential problem they have. So, first, technical requirements. Depth. It's really your concern before you put the patient on the table, because the device allows you to treat a vein which is in the range of 9 millimeters to 24 millimeters, because the device is a fixed focus device. So you can zoom for the moment, and you have to take care of the skin. So the maximum depth depends on the technical requirements of the device for the moment. And the skin protection is really about energy. And I have here a slide to tell you what it's about. So you have the skin and you have the vein. Your beam, your HiFU beam, will go through the skin depending the energy you're throwing through the skin.
Willem,
Yeah.
your slides aren't advancing.
Oh, sorry.
Thank you.
Okay, is it okay this way?
Yes, that's fine. We can see them now. Thanks.
Okay, so the beam, the energy will go through the surface of skin, but if the vein is closer to the skin, and I hope you will be able to see what's happening then. Okay, I will move back to, I don't know if you could see it, but if, let's do it this way. If the vein is here, you have to send the same energy through the skin because it depends on the diameter of the vein, and you will have all the energy going through a smaller surface of skin. So this is a risk of skin burns. So that's the reason why you have to respect the distance between the device, the skin, and the vein. The device is helping you because there is a skin tracking system that will cut off the energy that you can send to the vein if you're too close to the skin. You also have a cooling system that will allow you to protect the skin, but it won't avoid any risk. So your first concern is depth, and the vein is not too superficial. So the depth management is quite easy. For the minimum requirements, you can inject some water under the skin to push down the vein. Beware not to blur the treatment area, especially with perforators, because you lose the visibility of the vein sometimes, and you just have to wait for it to vanish. Play with the device, because the engineers gave us two kinds of settings. 1 second, 0.5 seconds. That you can be more superficial without lowering the energy range, especially with the 1 second parameters. About maximum depth, you have to be careful when you weed out your patients. What you have to do is a positioning test. That's what I personally do, because especially with fat people, the grease will compress and the whole block of vein plus fat will go down, and you won't be able to compress the vein, which is necessary to be able to apply the energy, and you won't reach the vein. It will be too far. So keep that in mind, not too superficial and not too deep. It also means that you have to treat for the moment under the fascia, and you can treat the tributaries. So this is a thermic treatment. So keep in mind that the nerves, in order to work with maximum safety conditions, just keep in mind it's thermic. So listen to the patients. Sometimes they will tell you it hurts. If it hurts locally where you're treating, it's okay, and we're talking about that in a few minutes. But if they already say, oh, it's going down to my ankle and so on, it's okay with one shot, but don't repeat it. Listen to the patient. The way to get rid of that is just moving slightly the treatment head, going to another place, finding another shooting angle to get rid of the vein position, and what I try to do is to locate the vein, the nerve, beforehand with a very high frequency probe, but obviously you can't see it anytime. So first, listen to the patient and keep away from the leg part of the great saphenous vein for the moment. So, pain is a cultural and personal thing. As I mentioned here, you can have patients who will really not complain about having sclerotherapy and will hate having YAG, for instance, in spider veins, and the complete opposite. It won't be painless. It's crystal clear because it's energy and you hit the vein, sometimes in the middle of the muscle. So what we can use is explain, relaxation, hypnosis, a lot of small things to make the patient understand what's happening, because usually after a few minutes of treatment, they understand what's happening and the pain goes down. And you first really have to explain, because it's something that you're not really aware of or used to when you go to the doctor. The first impression they have is kind of deep pressure inside, and they need to know if it's normal or not. And sometimes it's just like cramp. Then when you're set and you can shoot, the heat process will start to show off. And sometimes it's quite intense, but you know, it grows very quickly, but it also plummets very quickly. So once the patient is comfortable with what you're doing, if you explain it clearly, it's quite easy to treat any vein. Indications, well, do whatever you want.
Guillaume,
Yeah.
I'm afraid your slides haven't kept up with you. Thank you.
Okay. Did you get that?
We have now, thanks. We're on pain now.
Oh, okay, sorry. So do I need to come back to something? Or is it okay for you?
No, you're just on pain at the moment.
Okay, so here, indications. I can move on. Okay, so as Teresa said, if you're a Shiva believer, you can use it. And it's true that it can be a quick and fast procedure. Whatever you want, until you respect the rules I've just mentioned about depth and the nerve. So that's really simple. You know, I can't say anything more about indications. I try to treat some stumps too with a great success. So usual question we have, DASAs, miters, and other questions. So you don't have any limitations in terms of diameter. Bigger veins will need just more shots, and it makes the procedure longer, but it's not an issue. The length, the longer the vein, the longer the procedure, of course, because you have to treat slice after slice after slice. That's okay. It's then your choice to stop and use foam or anything else. And so don't treat the leg part of the great saphenous vein because of the nurse consideration. So the tributaries explain why it's not possible to do so for the moment. And yes, I try to treat people who had recurrences after thrombosis or sclerotherapy, and I have to say that it didn't work out very well, but it was in very early moments of my training, so maybe I need to be back to this. Here, a few examples of different things you can do. So I hope you will be able to see this slide with a Giacomini. I did an ASVAL procedure. There was strong reflux on the Giacomini here and feeding the short saphenous vein, and I chose to close the Giacomini. You see here my daily routine with the measurements of depth, minimum, maximum, and the diameter of the vein. And here the results just after the treatment, 10 days after, and here 6 months after, it's clearly fibrosis. I will try to show you the video here of a stump treated with the device. This patient had some sclerotherapy before, but no signs on the vein wall, just recurrency. So we could close it too. Here, a perforator, external part of the leg. The patient did experience some pain because the bone was very close, of course. You see, it's 3 months after. Here, another leg perforator, 8 months after, everything is closed. And when you work on perforators, you work on the fascia first. You want to use the fascia to really close the vein here, and then you can choose to go down, go up. I usually choose to treat the fascia to really close the vein there and then go down a little bit. You have here short saphenous vein recurrency that has been treated with crossectomy stripping. So you can see here that the depth is not, it's a very superficial vein, but with a little bit of injection and just under the skin, I could push down the vein and treat it with a good result 1 year after. And here, this is just a regular great saphenous vein treated, and you have it on video. So just before the treatment, you have here day 8. Sometimes it's scary because it could look like just thrombosis, you know, at day 8, but after 6 months, everything is really closed. And to make sure, just here with color flow, yep. There's nothing going through the vein. So, patient questions and expectation, because it matters. If they ask you if it's non-invasive, yes, it is. Will I have no injections? No, you may have additional sclerotherapy on tributaries and to manage pain of the depth of the vein. Can be a solution to a problem that can be recurrent or left behind. Yes, perforators, stumps, it's really helped me on those specific situations. Be also aware that sometimes if you intend to treat long parts of the vein with elderly people, sometimes arthrosis can be a concern. But the beauty of the device is also that they need to get up and to have a drink and be back to the treatment. It's possible. And I usually mention men because pain management is sometimes challenging with men rather than women. Thank you for your attention.
Thank you very much, Guillaume. Very interesting. We were having a discussion actually at our place, and we certainly find that men are much less good at small amounts of pain than women, and we found it when you're choosing your patients, it's quite an important sex difference. Just one more thing to say again. Once again, I'm just going to give a little rounding up talk because we've had 3 excellent speeches. I hope people have been able to see all of the slides, and if not, we'll be posting them in any case on the follow-up. And we're going to ask the speakers to also supply a video to those slides again to make it really clear, because I think some of this information has been excellent tonight. If you do have questions, please click on the Q&A at the top rather than raise your hand, because that way we can actually get round to answer the questions, hopefully before we finish at 6:30. I'm just going to share my presentation very quickly now, and hopefully we're going to get on to move that out of the way. So as if everyone else, can everyone see that? I hope so. So I'm just going to, what are the take-home messages then from, sorry, can someone's got their microphone on, if you could just take that off, thanks. So what are the take-home messages that we've got so far about HiFU, which is this new method? Some of you might have seen this before in my presentations. It's quite interesting that we've always thought that progression of varicose vein surgery has been from open surgery to minimally invasive endovenous thermal ablation, and everybody expected it to go to non-thermal ablation, but still minimally invasive endovenous work. And then suddenly, out of the really unexpected to most of us in 2019, this non-invasive venous ablation came out, and looks like it might become the more exciting option. So in December 2019, I published this paper. It's got some of the very early techniques in it, and it's actually free to all. If you look it up under current medical research and opinion, you can access this directly through PubMed or online. And it just states what I think we're all starting to say, that this is probably going to be a very disruptive technology, just as disruptive as endovenous surgery was to open surgery. But why is that the case? And really, more than anything else, is it works. And I think when we look at anything else, and we can, as with any new device, we always talk about the different techniques, the different ways of looking at it. But the most important thing is, does it actually work? And I think what Paolo showed before is it does work. And this is our 1-year results from the early pulses. You can download the preprint. It's already there. It has been submitted for publication as well in peer review. But as we all know nowadays, peer review is so slow. We now have the College of Phlebology preprints. You can go straight to that through the College of Phlebology website, and you can download the original paper that's been submitted for publication. So these are in the public domain. And what we've shown is on a survival graph, we had, with our learning curve as well, a 97% 1-year closure rate. And this was, as I say, with the original machine, with our learning curve included in it. So when you compare that to the early results of endovenous thermal ablation, we're already really up with the big boys. And with the IPVs, it's 84% closure now 1 year. And I think the histology shown by Paolo shows us something towards that. And I thought with Paolo's talk, and as I say, we'll make sure that it is on the finished version that we're going to put up online. I think if you didn't manage to see all of it, do come back and look at it again, because the thermal effect is very interesting. There, as Paolo said in his talk, you can get this complete extravenous thermal ablation, which is what we expect with endovenous thermal ablation. You actually get a complete ablation. But you can just selectively choose different leak points, and therefore you can do a Shiva type approach, but still occlude the vein. But what's quite interesting, especially with those people who argue that foam sclerotherapy works by reducing the volume without necessary occlusion, you can also get this thermal shrinkage, which may be an alternative way of reducing reflux to subclinical levels. So this does allow different treatment strategies. So although we already know it works and you can already use the device, you could actually have your own strategy as to, and you can modify it to what your beliefs are. And so there's you can ablate truncal reflux if you're coming from an ablation background, incompetent perforated veins if you believe that that should be done. And we've had particular success in neovascular tissue, where patients really, the neovascular tissue is too big for foam sclerotherapy. You could do a hedgehog technique, but that's quite uncomfortable. Whereas we found that this is a very I would say painless, but it's not as painful technique, and certainly nothing invasive in. And a lot of patients these days do not want anything invasive at all. The possibility of shrinkage opens up a whole new sort of way of thinking of treating veins. And of course, because of the selection, you also do the hemodynamic approaches completely non-invasively. And as you've heard, there are limitations on vein depth, but as Guillaume has said, you can actually cheat this a little bit by using degas saline to push the vein deeper, or you can increase the pressure in the treatment balloon. And also we've found we can raise the bed as well, and that does give you a bit of extra flexibility over what you'd think is the limits of the vein. But as this is going back exactly to what Guillaume's just said about the pain, it is very, very patient dependent. So all of our patients, we give them a clear explanation of what they're to expect. I usually flick their skin and say each of the half-second pulses feels like that. And often people say it's less painful, and so other people, especially if they're quite nervous, say it's more painful. It does depend on the patient. It also depends on the position of the vein. And certainly if your great venous vein is sitting on the muscle in a slim person, I always think a little bit of local anaesthetic is probably required. We give all of our patients a stress ball. We have a published PhD that shows that talking to the patient and stress ball usage in the hand are the only two things that actually reduce the pain and anxiety in our randomized controlled studies. And also Nefopalm orally, about 20 minutes preoperatively, really has been a game changer for us as well. This is a very good non-steroidal anti-inflammatory, long-acting, and you give it about 20 minutes before the start of the procedure. And this means that currently about 60% of our patients have had absolutely no local anesthetic at all. 20% have had just very selective areas, just if it's by the bone or by the muscle, and then 20% of patients who've actually opted because they're very nervous or because they find it painful, and we actually go for a targeted anesthesia where we shrink the vein right away and treat it as a solid core. And although you are injecting with that, the patients don't feel the injections because it's under the cooled balloon, and you see the vein very easily as a solid structure, and it actually makes a very easy technique. But Guillaume did point out, and this is absolutely essential, beware of nerves and any nerve pain. And then what Teresa pointed out is the advantages. And to summarize a lot of her talk, it was to say there's safety because there are no wounds. It is truly an outpatient treatment, patients coming in without any need for sterilization or operating rooms. I thought what she said about age restrictions is very important, especially in the elderly, and you don't need to stop anticoagulants. There's no compression needed afterwards. Patients that literally walk straight out, and some of our patients more recently have not even got undressed. They've just got up onto the bed, we've done it, and have walked out. And as she said, you go back to normal life very quickly. The cost balance, I think, is very important, but also if you're running your clinic, there's also this very big thing at the moment about patient choice. And we've certainly had a couple of patients who come along who won't have any vein treatment if it's invasive. They're worried about needles, they're worried about infections, they don't 100% trust sterilization. And we've got patients who really come along and say the only reason I've come along is because it's non-invasive. And I do think that as the word gets out, that's also another thing that's going to help with the fact that when you've bought this, which is it's an expensive machine because it's new, but there's a large number of patients out there who really do want it. So the one thing that isn't covered, and this is whenever you give a talk on radio frequency, microwave, laser, high intensity focused ultrasound, whenever we talk about the treatment of the network 2 veins, the truncal veins or the incompetent perforated veins, so often we forget to talk about the varicosities on the surface, and that quite often is left out. And when I read papers and review them, quite often that's also left out. And it's very important because if you are doing lots of phlebectomies, you're going to get a different immediate post-operative bruising and pain score than if you do none and leave them, and depending whether you get phlebitis or not. So we have to remember varicosities are not treated with high intensity focused ultrasound the same way as they're not treated with any of the thermal ablation techniques or even non-thermal ablation techniques, the catheter based. The truncal veins were sort of, at the moment it's a slow treatment, but it's speeding up tremendously and we get very good results. And the advantage of not needing theatre is a huge time saving. Incompetent perforated veins at the moment are so fast because you don't need to set up the theatre and clean it afterwards. And so really, if you're treating mainly incompetent perforated veins, this is a very viable alternative already. And the couple of cases we've had with severe neovascular tissue, again, excellent results with really minimal trauma to the patient. So do remember with the varicosities, what we're now doing with HiFU is we're doing an ablate and wait. In other words, we ablate the leak points. We stop all the areas where the blood is coming into the vein, whether it's the truncal vein, we treat the top 15 centimeters, 10 centimeters if it's small venous vein, 15 for anterior accessory or great venous vein. Wait, and then most of those patients, if you wait 3 or 4 months, if they need anything, it's just a little bit of foam sclerotherapy, and that delayed foam might not even be needed. So is it a useful treatment? It certainly is for most veins, but I do think that we need to be careful to think a little bit outside the box when it comes to time and strategy. So initially, when I was a junior surgeon, we would bring patients in for one operation, whether it's 1 or 2 legs, under a general anaesthetic. You did try to do everything at once. It was very traumatic for the patient. The results were generally very poor, as we know. And then when we moved to endovenous surgery, we tried to repeat that, but quite quickly we learned that if you want to do it as an ambulatory technique and under local anaesthetic, there's no reason to try and do it all at once. You get much better results if you split it up into different sessions, maybe one for each leg for endovenous and then foam sclerotherapy later. But by getting patients in on different days and for less trauma each time, you end up with better results and probably doing less overall trauma, because once you've switched off some of the reflux, many of the veins start shriveling away. And I wonder if HiFU, as we go through, because it's a truly outpatient procedure, I wonder if the future is going to be more visits, but less done at each visit, much less trauma, and therefore patients not thinking this as a life event, but thinking more like going and fitting, first all sort of having their teeth measured as you go to the dentist for an implant. You'd have it measured first of all, you'd have implants made, you'd have a fitting, and you go several times, and each one's not particularly traumatic, but at the end of it you end up with a lovely result. And I wonder if by using this sort of strategy, rather than sort of arguing about just ablation or Chiva, why we might end up with much better results for our patients. And I think it's a very interesting concept that to get to the end result, there might be a different pathway to get there. Thank you very much for all your attention, and now we'll look to answering some of the questions. I'll open this up to my colleagues. First of all, and this is the big question always with this, and perhaps we can start off ladies first. Teresa, perhaps you can start first. There's the question is, how fast is it, and can you give examples? Can you, sorry, I'll just switch your microphone on. Oh, can you switch your microphone on? So I can't do that.
Okay, can you hear me now? Yes. Okay, sorry. So actually, from the moment the patient comes into the consultation room where we have the machine, until they go, is like 45 minutes, 45, 50. It really depends on the patient. And for us, it might be a bit faster because we only do Chiva. So we will only treat the endo leak. So of course it will be faster. So I would say around 45, 50 minutes. Sometimes it can be an hour if the patient is very anxious and you need to talk to them a lot, but a normal one could be like 45 minutes. So comparing to a normal surgery, when you have to clean up the operating room, take the patient inside and then back, it's faster to me. Yeah.
Thank you very much. Guillaume, what's your views on time? Can you unmute?
Yeah, okay.
Thanks.
Well, as I use a different technique, I want the destruction of a full part of the vein. It may last longer on great saphenous vein, but as you said, they speed up the process so dramatically that it may lead me to treat during 1 hour and 15 minutes of full great saphenous vein, 30 centimeters or something like that. But you can also treat 1, 2, or 3 perforators in 30 minutes. So it really depends. And on short saphenous vein, with the new improvements and especially with the HD and the new imaging system, it's so easy to go along the vein. I could treat just last Friday a full short saphenous vein in 35 minutes. 35 minutes. So yes, everything has changed since we had all these improvements with the device. But my choice, as is to treat longer segment, takes time. I do assume that.
And Paolo, what's your experience?
I can speak with hands. It's very. You listen to me now? No. You listen?
Yeah.
Okay. I don't know why there is some echo, because I feel also echo when you are talking. So back to the time using SONOVEIN. As Teresa does, we don't perform Shiva, but we perform conservation of trunks, and we treat also GSV in small parts. looking for shrinkage most of the times, but I have to say that we get, when we decide, we get 92% of closure. So if you can decide to do what you want with SONOVEIN on the vein. But in any case, to treat a patient, now we take 30, 40 minutes. With HD, not more. Sometimes it's 1 hour when you have to treat both legs in the same patient. So it's very useful because you can do that because you use only one device, and so it's saving time and saving also money. The problem is about the patient that has to stay 1 hour in the office. But I agree also with all of us, all of you, because with the new machine you can have a better visualization, and you are faster than the first cases we did. There is a curve, a learning curve is quite longer. It's not so easy to learn how to manage the robotic system, but when you learn that after 20 cases, you can do very quickly. And I think that's all about the anesthesia. I want to spend some words about the anesthesia, because we sometimes try to use without, and if the patient is well informed and you talk with him, I think they can support, they can stay for some spots without moving. But we prefer to make intradermal lidocaine anesthesia, because if you use the intradermal only in the dermal system, you shock you close the shunts between the nerves. They feel only heat. They don't feel pain. They feel warm when you treat, but not pain. But we are starting with introducing oral drugs 1 hour before, with ketoprofen 100 milligrams and benzodiazepine 1 hour before, in anxious patients to have better response. So we will start with the protocol, with starting randomize 20 patients, and to treat 10 patients with only local anesthesia and 10 patients only with oral pill. And we will in the future, I think in 2 or 3 months, I will have the results.
Thank you.
Okay.
Thank you very much. We've only got time for a couple more questions, really, because we've already overgone time. I'll just answer a couple. I know there's lots coming on the chat, but we're only answering those at the moment on Q&A.
Do you hear me?
Yes. So we're just going to answer a couple of very quick questions. Melissa's asked about light therapy, ultra waves, or radio frequencies, personal devices. These devices only affect down to the skin. They don't affect down to the level of the veins we're talking about. So this is a medical device affecting centimeters deep, not the sort of ones you can get from a pharmacy, which are personal, which are very low power. So they are very different. Somebody's also asked about the ablate and wait idea and said that that's not what NICE says and patient choice. I think you have to remember NICE and patient choice are on historical studies that were done with endovenous thermal ablation, and to say the same results from HiFU, we'd have to repeat it now that there's a completely different way of treating the veins. Let's try and go ask another question. This is a question that's going to just I'll throw out there, and to Teresa first of all again. Somebody has asked, can a standoff with bubble-free water preventing defraction be used for very superficial veins? Do you think by using an additional standoff, obviously the balloon's already a standoff, do you think you could use an additional standoff?
Can you please repeat the question, because I
Yeah.
didn't listen, sorry.
I think the answer, yeah, the question is with the cone shape that Guillaume had mentioned. The answer to the question is they saying, can you stand it off? In other words, push it further away. I think the concentration of the flux would probably burn the skin, though, don't you think? If you push if you got an even bigger balloon as such, and actually push the thing off, so you were treating the question is really, can you treat an even more superficial vein? Do you think that's possible with this technique?
I don't think that would be necessary, because actually it's what you said, you can just burn the skin. So I personally, I don't know if I understood the question right, but I just don't think it makes much sense, because you can burn the skin. So why should you go so close to the skin?
Thank you. Guillaume, I think that's what your diagram showed with the cone, isn't it? That even if you pull further away, you actually get more concentration of the energy at the skin. The circle's smaller, isn't it?
Yeah, this is just geometry. As you have to shoot with a certain amount of energy depending on the diameter of the vein. If the vein is too very superficial, you have to send the same amount of energy through a smaller surface of skin, so you will burn the skin. So as Teresa said, it's not relevant for the moment with this device, and a larger balloon will just give you more depth. That's true. A larger probe, a larger head will give you more depth, but it's not more superficial for the moment. It's not really relevant.
The thing we'd have to ask the scientists if they could actually get a much bigger cone aimed much more superficially for those. But then the question is whether you get whether the heat heats the skin, but not with this device. I think is the answer. And we'll call it to a close after one more question. I'll ask one more question, then just for all the people who are here, if your question hasn't been answered so far, we will put all the questions up on the College of Phlebology website, and all of them will be answered, and we'll have all the experts have an opportunity to answer your questions in text or video, so do check back on the website. But for the last question for this session, there's been asked by Andreas has asked, I'd like to know if vein fibrosis can be palpable in a thin patient, and if you can feel a fibrosed vein, does it reduce the quality of life? Teresa, what would you think? Have you found that?
I don't think, because it's not the same as the fibrosis you get with a thrombosis, for example, that you might feel it. This will, over time, will just be eliminated, so they will not feel anything. At first, they might feel something, but then it will just disappear. So I don't think it will change their quality of life.
Thank you. Have you found this at all, Guillaume? Have you had a patient with this yet?
Yes, the same. When you treat sometimes very superficial veins with endovenous laser, you can have this feeling, but I did not experience that. And I had a few very fit patients, and they really did not complain about anything for the moment.
And Paolo, can you answer that? I don't know if we technically can get your answer. No, I think we'll probably call it a day. Okay, I'd like to thank all of the panelists for their excellent presentations. Omar, who runs the College of Phlebology, will get edited highlights of this onto the website and onto YouTube. And please do check back there, because the histology, if you missed it, will be put up on that presentation. In addition, all of the questions that have been asked will be answered there, so that you will get an answer to your questions. If you do have any other questions that you do want that you haven't actually asked so far, at any time, please do just email us at the College of Phlebology. That's collegeofphlebology.com, and we'll be able to pass your question on to the relevant doctor, or be able to answer it online for you, whichever you like. Thank you all very much for giving up your evening to come and speak to us.
Thank you.
Thank you. Bye-bye there.
For having us.
Thank you to everybody. Thank you so much.